Hello, everyone, and welcome to my talk on evolution of total joint replacement and the technology today. My name is Erik Bowman from the Boulder Center for Orthopedics and Spine. My disclosures for this, these are my opinions on technology and implants where the data is not presented. I have no royalties, personal or family connections to any of the technology or companies. This is me. I'm a hip and knee reconstruction specialist. I did fellowship training specifically in hip and knee joint replacements in Louisville, Kentucky. When I was there, I trained under Dr. Arthur Malkani, who's a designer of many Stryker products, including the femur stem for the hip replacement. And he's also highly consulted for many of the products, including the MAKO Robotic Surgery, which we'll talk a lot today. Also, I've done over 500 cases with him in hip and knee revisions, which are basically redos, and also MAKO robotic technology. I did my residency in Omaha, Nebraska, just down the street, if you will, and trained with Dr. Kevin Garvin, who is president of the Hip Society and amongst other faculty. Interestingly, I've had a lot of training in hip and knee reconstruction, in which most orthopedic surgeons only do 20 weeks of training. I did 18 months out of the 5 years I was there. So enough about me, more about you. So question, have you ever been diagnosed or thought you have had arthritis? Also ask yourself, how many people do you know who has had a hip or a knee replacement? Likely, and I'm willing to bet that most of you are here because you have aches and pains and probably think you have arthritis, and that you probably also know somebody that's had or may have had yourself a hip or knee replacement in the past. And so hip and knee arthritis are very prevalent. And in fact, 54.4 million Americans have some form of arthritis. In 1 year alone, we do about 450,000 hip replacements and about 1 million knee replacements in 1 year as an orthopedic group in not group here, but in America alone. And it's even going to dogs as well. So even our furry friends are even getting hip and knee replacements now. But arthritis has been around for longer than we could ever really remember. In fact, archaeological data shows that the Neanderthals 35,000 to 350,000 years ago showed signs of arthritis, which is likely due to their hard lifestyle of walking and building tools throughout their lives. Even in the Americas, we've had great evidence of arthritis dating back to about 6,000 years ago. So to your right is a picture of knee arthritis in a 6,000-year-old archaeological excavation. This is of an 80-year-old woman in which, as you can see, there's been wearing away of that knee. And you can even see the bone spurs on the bottom side of the tibia, which is on the bottom side of the picture. And this is likely related to the labor and the harder lifestyles of ancient times. Even in ancient Rome, there's been archaeological evidence that many of these young patients or young laborers had immense arthritis, especially in their knees, hands, and in their backs. The average Roman worker in these excavations have shown that their bodies are riddled with arthritis as well as broken bones. And they often only live to 30 years old. And so arthritis was very prevalent in ancient Rome and Greece. And back then, they even treated these joint pains with wooden cages shown in the archaeological records. Ancient Egyptians also had arthritis. It was first seen that they were related to the occupations of the different people of ancient Egypt. Scribes sat cross-legged, and so this would increase the forces that they saw in their hips and ended up having more prevalence of hip arthritis, whereas the peasants who are constantly bending and lifting had spine arthritis. And we even have data that shows in the records of the hieroglyphs that the treatments for these pains were very variable, but they were natural as well, such as fat, oil, honey, and bone marrow were given to these people to hopefully keep them from having pain in their joints. Even over in the East, there was great recordings about arthritis and other ailments. There was an ancient textbook called the Naching, which was basically a compilation of ailments described by doctors that described many different kinds of pain generators. This is a textbook that's over 4,000 years old, even describing the aches and pains of the back and the knees and the hips. Interestingly, this book is actually a dialogue between the emperor of the time and Dr. Chi Po. So a little bit different kind of text that goes along with this book, but it describes the pains that this emperor had as well as his servants and close family. This is also the first reference to acupuncture, and interestingly, it's virtually unchanged, the methods used from this book today as far as acupuncture goes. And so fast forward several millennia and we get into surgery for joints. So the first surgeries for joints were mostly for septic arthritis, so infections that go into the bones, especially the knees and the backs. This was mostly most commonly due to tuberculosis and also likely probably staph, something common even today. And so here's a picture of what it may look like back then. As you can see, it looks very painful. This often created immovable and painful swollen joints. And it could even be lethal because these were deadly infections back in the day. And so it often led to amputation of these limbs, which obviously is not a great solution to joint pain. But back then, this was the best thing they knew in order to get rid of pain in the joints. So Dr. Henry Park in England was sick of seeing all the amputations. There was many people that were coming back from war with amputations. There were patients that were being amputated for infections. And so he just devised a way to spare amputations of patients. And so he wrote a manuscript about a patient that had tuberculosis in his knee. It was an old Scotchman that came off of a boat that had completely worn away his entire knee due to tuberculosis. And what he had described here in this excerpt is basically removing the knee joint itself, but not removing the entire leg. And so this was your option back in 1781, was getting your whole joint just chopped away. But interestingly, this did very well, at least for pain relief. And so because of this, Dr. Anthony White in London did this for a hip. And so essentially, as you can see with the red circle, he removed this tissue from a hip that was also dislocated and infected. So by removing this joint, which is a surgery we do today, thankfully very, very rarely, but for joint infections that we can never get rid of, this does extremely well given the circumstances. So by removing all that bone in that circle, this was the surgery of choice for painful joints, including just arthritis. And so a couple of years later in Philadelphia, Dr. John Ray Barton performed what's called an osteotomy, or cutting of the bone to relieve the pain from a joint that was not moving anymore. And so if you turn your attention to the right, you can see his drawings from his manuscripts where in the hip, he would make a bone cut. And so by doing that, it allowed motion again through the hip, but there would be no pain because the motion was not going through the arthritic joint anymore. And so he would also apply this to knees as well as ankles, elbows, and other joints in order to relieve the pain. There was a letter from his hospital in Philadelphia that advertised this and said that he could do the surgery in 7 minutes. Well, if you think about back in the day, they didn't have anesthesia, so you'd want the fastest surgeon back then. So as things got more sophisticated, we started to experiment with biological implants. And so Dr. Leopold Allier in the late 1800s described taking tissue, biologic tissue, and actually putting it between the joints. To the right, you can see a knee. And as you can see, there's now a space over on the right side of the knee. And so by creating a space that wasn't there before, you got pain relief because the bones were not rubbing on each other. However, this did show some mixed results because the tissue would rub away. And so Verneuil advocated biocompatible materials, so other materials that are not your own, such as fat or muscles, in which Dr. Ollier would put. And so he used pig bladders, nylon, and cellophane as different objects that would go into these joint spaces to create some pain relief. However, this was never a good idea. The biological materials are going between joints, in which those joints see an immense amount of weight and also can wear away very easily. And so we advanced to more mechanical implants. And so Dr. Themistocles Gluck, he was a German surgeon in the mid 1800s, implanted the first hinge joint. Okay, so this was his description from his manuscript. So it's very rudimentary type of implant, but as you can see, it's trying to mimic actually what the knee is doing, acting as a hinge, or so we thought it acted like a hinge. However, this was made out of ivory, and so ivory was tough, but it also would mechanically fail with time though. So he designed other types, but he also applied this to hips as well. So Professor Gluck presented a femoral head replacement, so as you can see down on the bottom left, made out of ivory for hip joints that were destroyed by tuberculosis. But he experimented with other materials as well. He used nickel plates and screws. He used plaster of Paris, as well as powdered pumice with resin to restore the hip and the knees. However, none of these quite worked because, as you can think about, ivory would be brittle over time. And so he started experimenting with different materials. He tried to sew cadaver joints and amputated limbs from soldiers back onto other humans and failed miserably, as you can imagine. He proposed inserting artificial joints into the shaft of the femur, which was a big breakthrough at that point. Because this has now led to our modern day joints in knowing that it's safe to put implants inside the canals of our femurs and our tibias. But he also experimented with different materials and how the body behaved. So enter biocompatible materials, in which this helped advance our knowledge of how our body reacts to different foreign materials as we put into it. And so in the 1920s, American surgeon Marius Smith-Peterson created the hip caps. And as you can see in the upper right-hand corner, this was from a magazine showing an excerpt of Smith-Peterson hip caps from the 1920s. He experimented with many different materials, and these materials were experimented by Dr. Gluck in the past, in which these were what we call biocompatible materials, meaning that these materials would react well inside the human body. And so Dr. Smith-Peterson would experiment with these different materials and use harder and more durable materials as the time progressed. And so to the bottom right, you have his Vitalium hip caps that show up on the x-rays. And so what this did, it was create a capsule around the metal. So your body would actually create a film that was around the metal, and that would become your new hip joint. And surprisingly, it did very, very well for pain relief. Unfortunately, putting metal onto a bone can cause erosion of the bone. And so these would fail over time for the younger patients, but for the older patients, this did extremely well. But this did not do well for the younger patients. And back then, the younger patients were, 50s and 60s. And so Dr. George McKee in the 1950s experimented with metal for the replacement for the socket. And so he was the first surgeon to regularly use metal on metal hips. And this was his design, the McKee hip arthroplasty on the right. And he also used what's called a modified Thompson stem. So another surgeon that created a stem in which he cemented that metal stem into the femur. And then he adopted the cobalt chromium, which is a more durable, smoother metal in order to make the hip last longer. And so these advancements allow this to have the first good results of a hip replacement for the long term. In fact, 74% of the implants put in by Dr. McKee survived 28 years, which even in today's standards is exceptional. And so this was very popular to use from the 1950s to the 1970s. However, the popularity started to fade as we saw more complications, though. The complications of this were caused by the metal debris that came out from these hip implants due to the tolerances that were limited back in the day. And so these metal particles would lead to immense complications, and it didn't regain its popularity until the early 2000s. And so with better tolerances of machining of these implants, they became more popular in the 2000s. Unfortunately, history repeated itself. It was the most in vogue thing to do back in the early 2000s was to put metal on metal hips. Unfortunately, this has led to recalls as well as even lawsuits because of these metal debris, in which we'll learn later. So further developments from the 1960s due to this problem, there was many different kinds of renditions of different kinds of implants. So Dr. Ring, he created his own self-locking in order for it to fix in. And if you see in this top picture, he also put bone plugs into those little areas, into those little windows of the femur. And then Dr. Sivish, Russin, and Noyles created what's called the S-RON ROM stem, which is still used today, but obviously with more modifications. But this was the first modular stem that was used, where it gave you more options to recreate the anatomy for the patient. However, these again had the problems with the metal ions, and so Dr. Sir John Charnley of Manchester created what's called the low friction arthroplasty in the early 1960s, in which the principles of his design are still used today. He's known as the father of modern hip replacement. He used a metal femoral stem, so as you can see down below. He used the plastic cup, which we still use today. And the only thing that has changed is that we no longer cement the cup into the hip. Instead, they're all allowed to be bone ingrowth. But the principles that he used back in the 1960s and 70s, we still use today for reconstructing hips. However, the metal revolution didn't really hit the knees as successfully as the hips did. In 1951, Dr. Waldius developed a hinge joint made out of acrylic. And as we know, this does not do very well in the long run. And so in the 1958, Dr. Waldius created a hinge joint using metal after seeing what Dr. George McKee did. And so in the 1950s, he created the knee implant that you see to your right. It did show excellent pain relief initially because, again, you're getting rid of the arthritis. However, this was fraught with complications, though. It was a technically easy surgery to perform because he cut the bone pretty deep into the bone and cut all the ligaments out. But as we know now, you need some of those ligaments, not all of them, but some of those ligaments in order for the knee to last for a long time. And so the hinge does not mimic the complex movement of the knees. And so many of these failed due to loosening. And so there was more to be learned about the actual mechanics of the knee in order for us to replicate this to keep these from loosening over time. And so because of the complexity of the knee replacement design, there was many different types of designs that were made in the 1970s. Some of them attempted to spare all of the ligaments, while as others selectively picked them. And so one of these was the Gunston polycentric knee arthroplasty. As you can see on the picture on the left, you had the femur that had the pieces put individually on both sides. And then they put a piece of plastic in the middle on top of the tibia. However, this failed despite saving the ACL, the PCL, and all the other ligaments because of the wearing away of the joint. The Coventry geometric knee arthroplasty was the first one to actually have somewhat similar knee mechanics. As you can see, it's no longer a hinge and looks much more similar to what a knee actually looks like. He also advocated for sparing of the ACL and the PCL as well, in which this design did decently well, but had problems with wearing away of the plastic, which was the part that was on the tibia. Also was the duocondylar knee. Here's a picture of an x-ray as well. Again, attempting to spare the ACL and the PCL. However, again, this was fraught with complications as well. And so Dr. John Insall in the 1970s at the Hospital of Special Surgery in New York City implanted what he called the total condylar prosthesis. It was a design such that we created mechanical restraints for the knee moving back and forth so that we could cut out the ACL. And so if you look at your picture on your right, you see a couple of designs. You see the one on the left where you can see kind of a lip on the plastic piece on the bottom. That lip allowed it to have some stability, in which we still use today. Also, if you look at the picture on the right, you have that post on the white plastic piece. And so that post mimics the PCL. And so because of the lip on the plastic piece, as well as that post, you no longer needed the ACL or PCL. And so because of this, you had a bigger piece of plastic that could be cemented onto the tibia. And so the fixation was better, and so therefore it lasted longer. And so modern hip and knee replacements has evolved since the 1960s and 70s, but the principles that Dr. Insall and Dr. Charn Lee created are still part of what we learn and apply in surgery. And so now we're looking more into how to make these things last longer. And so the most recent problems from these designs, such as polyethylene wear, have been addressed. And so polyethylene wear was a big problem in the 1980s and 1970s. Mechanical loosening has been an issue. As you can see it with the black arrow showing you that the shell of the socket has turned in a clockwise fashion or counterclockwise fashion, which led to loosening. Also, dislocation has been a big problem even today as the #1 complication of hip replacements, as well as restoration of the anatomy. And so here is a patient that was born with her hip all the way up on the side of her pelvis, nowhere near the socket. And so with modern technology, we're able to bring that hip back down, but back in the day, we were not able to. And so we had to try different modalities, such as cutting away the entire joint. That would be the treatment for this, just like they did in the 1800s. But with today's technology, we're able to restore anatomy much better than we were even in the 1960s and 70s. And so we'll talk about these recent problems and how technology has changed just recently on dealing with this. So we'll start with plastic wear. And so conventionally, we've had metal on plastic. And so with conventional plastic wear, you can eventually wear away that plastic of your socket or even on the knee, which can cause problems. And so this can lead to severe osteolysis, or what we call bone absorption. If you take a look at the picture, you'll see that that ball is no longer centered in the cup, And then if you look just to the left of where that cup is, you see this kind of billowing out. It's kind of like a small pocket or bubble that's forming. That's your bone being resorbed because of the immune system eating those plastic particles. And so that can eventually lead to loosening of the implants, as you can see in this catastrophic failure. This obviously would lead to early revision as these plastic pieces would wear away. And so the traditional solutions for this were to build a thicker poly, so a thicker piece of plastic. But when you make a thicker piece of plastic, you limit how big the head sizes of the femur can be. And because of that, it was easier for it to dislocate. And so with modern technology, we've created alternative bearing surfaces. That is, instead of using metal on plastic, we've experimented with different kinds of materials. And so we have things like metal on metal, which we've seen earlier, which has excellent wear properties. If you take a look at the picture on the right, the one to the furthest left is conventional metal on plastic. And as you can see, it wears away the plastic a substantial amount compared to a metal on metal hip. There's also ceramic on ceramic, which was very popular in the early 2000s as well. This has the best wearing properties, as you can see on the far right. And then we also have ceramic on plastic as well, which is the one towards the middle, which has exceptional wear rates that is similar to metal on metal, but it doesn't have the problems with the metal on metal hip replacements in the past. And so to touch on the details of the metal on metal hip replacements, again, they were popular in the early 2000s. It's 60 times less wear than if we just had conventional plastic on metal. But however, it was again fraught with early failures, and this was due to metallosis. This is actual tissue from a patient that was taken out because of the metal particles inside the hips. You can even see black, nasty, soapy-like or grease-like material that is aspirated out of the hips, and it can even create pseudotumors. Here's an MRI of a giant tumor shown with the white arrows that was forming around that metal implant. Now, this isn't cancer. This is a tumor, a pseudotumor or a false tumor that is created by all that junk on the left picture. And so this has led to recalls and lawsuits from these hip implants. However, the Birmingham hip resurfacing metal on metal has had an excellent track record, which is still put in today and does very well for very young patients due to the wear properties. But there's always that risk that this could possibly happen. Ceramic on ceramic seems like it would be great, right? So you have the excellent wearing properties of ceramic on ceramic, but there can be catastrophic breakage of these ceramic materials. Just like a porcelain vase, when it's dropped, it can shatter. And so that's a really bad day when that happens for both you and the surgeon, picking all these pieces out of you. And then also, most interestingly, it can cause a squeak. So I'll show you a video of what that looks like. And so this is a patient that had a metal on metal, ceramic on ceramic hip. And you can hear him squeaking as he's going up and down the stairs. And so you can imagine it's probably very annoying, not only for you, but other people, knowing that you're coming up behind them. And so, there's been a lot of technology that's been put into plastics because that was the limiting problem with it. Everything functioned very, very well. It's just that the plastic wore away so quickly. And so a lot of research has been put into making and manufacturing the plastics to be more durable. And what it comes down to is the sterilization process and the manufacturing process. So the sterilization has was found that the oxygen in the chambers when we sterilized it caused accelerated wear. And so we've changed it so that we sterilize it in inert gases. We've also changed the way we manufacture the plastic. The reactions to make the plastic create what's called free radicals. So these are dangerous, very powerful oxidative type of material, particles that go and destroy the plastic and cause it to break over time. And so in order to get rid of these free radicals, we've tried different manufacturing processes, such as annealing or melting of the plastic, and even doping it with vitamin E, which is an antioxidant. So preventing oxidation of the materials, which is caused by the free radicals. And then probably the most important thing out of everything is cross-linking. So another type of technique where we cross-link these plastic molecules so that the material lasts a lot longer. And so now with today's technology, these modern polyethylenes last much longer than they did back in the 1990s. And so with highly cross-linked polyethylene, plus or minus vitamin E, because not all plastics will have the vitamin E, these have shown exceptional wear patterns. At the University of Nebraska, where I did my training, we had one of the world's largest labs that experimented with these different types of plastics. And so these have shown exceptional wear properties, which are approaching close to what the metal and ceramics would give us. And so because of this, these are great options because they don't have the complications like we did see in the 1990s, where we saw that bone being resorbed or bone being taken away anymore. We don't see that very often. And so the complications from the plastic don't arise. But we also don't have the complications from the ceramic on the ceramics, the squeaking or the shattering. We don't see the metallosis that we see with the metal hips anymore. And so because of this, this is an excellent option. It also allows for a thinner piece of plastic. So now we can have bigger femoral heads so that there's less likely for this to dislocate, which is helping us with one of our common complications. And so we don't have the data currently that says that this will last 25 years or more, but we can extrapolate by the data that was getting put out about these wear particles from the University of Nebraska and the University of Tennessee. We can hedge our bets almost that this may last us 25 or 30 years with the plastic bearings. And so here's just a summary of basically those different bearing surfaces and the advantages and the disadvantages of each of them. But there's other things we can do. There's advanced technology. And so things like computer navigation or advanced robotics or even sensor technology to show how much pressure we're putting on these implants. And so we can tailor it so that we put less pressure on them so that they will last longer and see less wearing of these. As far as addressing the loosening of the implants, there's been great advancements as well. So as far as hip implant fixation, we traditionally fixed the femurs with cement. So we put cement almost like a caulking into the femurs, as you can see on the right. You see kind of this shadow, this white shadow around the implants that are put in. And so this is still popular in Europe and Australia today. However, it's associated with early loosening because it's kind of like a grout in a way. It loosens with time. And it's also highly dependent on the technique. If you have not done a lot of these or have mastered the art of this can be very challenging to get long-term fixation. However, with fourth generation techniques, it's now having comparable survival to cementless. And this may be an option for some patients that have really weak bones because it's less likely for us to break your femur in surgery, which is bad, if we use cement. So cement is still an option that we use today. However, in today's United States, we use cementless technology for about 90% of the hip and knee replacements, hip replacements. And we'll talk more about knee replacements here in a second. So with the cementless technology, there's been great advancements. We've created implants so that they are machined to fit the bone more perfectly. So our machining methods are better in the during the operation, as well as making the actual implant itself. We create technology, as you can see down below in the circle, where the bone is allowed to grow into the metal now rather than onto the metal like they did back in the day. And so allowing the bone to grow into the metal, this creates great fixation, which hopefully will last you for the rest of your life. But in addition, there's also special coatings we can put on called hydroxyapatite, which is similar to the bone structure. So we do have hydroxyapatite inside our bone. And so basically our cells in our bones think that these implants are actually bone. And so they basically go over to the metal and pretend that it's bone and start to lay bone inside the metal to help fix it. As far as knee implants, the cement implant fixation is the gold standard that has been put in since the 1970s when Dr. Insall did it. And this is still popular today. However, there's been renewed interest in cement technology or cementless technology due to improving techniques in surgery as well as manufacturing of these implants. And so these implants have improved due to 3D printed technology, as we can see with this implant below. So this entire implant is 3D printed in factories so that we can tailor it specifically so that it has exact size of the pores in the metal so that the bone will grow into that because it, again, thinks it's actually bone. We've also improved our surgical techniques. Surgical technique is absolutely super important for implant fixation of the knees when you use cementless technology, because with cement, it just fills in those defects for us. It makes it easier. But with improved surgical techniques, we're able to do this. So it's highly dependent on perfect cuts in order for the cementless technology to work. And so we'll talk more about how we've improved our surgical techniques so that we can make this a more standard of care for patients. So the advantages of having a cementless knee is that it theoretically will survive longer. We're not depending on that grout or that cement to last forever. Instead, we're allowing the bone to grow inside to the implant so that it creates a permanent bond. And it's also a quicker surgery. We don't have to wait for the cement to cure inside the body either. As far as hip dislocations, there's been great advancement recently for decreasing the risk of dislocations. It is the #1 complication of hip replacements, and the three primary reasons of hip dislocation are previous hip surgeries, so patients that have had hip surgery in the past, soft tissue damage, so damage to the muscles and the tissues around the hips can lead to dislocation. And then finally is surgeon error, so malalignment of these components, meaning putting the components in positions that allow it to pop out. And so this is what technology can really help us with, is with aligning this. And so advanced techniques come in all kinds of different modalities. Most importantly is surgical technique, making sure that we spare the things that we need to spare and repair the things that we repair, in which this has now become standard of care. But that's not the only thing. You can still put the components in a bad position. And so now we've used different technologies. We use X-ray inside the operating room to help guide where we put the implants. We can use computer navigation. This is what we call joint point in the upper right hand side, which is an excellent tool for placing the components and sizing the components properly to fit your anatomy. And so this is new technology that we've never had before that helps us put these components in properly. And then there's also robots, and in which there's only one robot on the market currently that can do hip replacements. And so by doing these types of technologies, we can feel confident that we put your components in the proper position. Restoration of anatomy has also been an issue. And so robotic surgery has played a big role in allowing us to plan your surgery in advance. And so here is a picture of what an interface of what the surgeon will see during your surgery, showing all of your numbers as far as the things that we can do to tinker and change how we put the implants in. And then we can intraoperatively, that is during the surgery, personalize this to your anatomy. And so here's an interface as we're recreating the anatomy that you have so that we give you the best functioning knee possible. It also allows for precise bone cuts. As you can see here, there's a blade that's cutting away on the femur. So we as surgeons are looking at this computer screen, not even looking at your knee as we're cutting, because of the technology that the robots allow. And so we're basically just trying to take away all the green part right there to put our implants in. And then as you can see here, there's a boundary line. So you can see this green line that will not allow that saw to go into. No matter how hard you press, you cannot push that saw into the knee any further. And so it protects all the soft tissue. So it protects your ligaments, it protects your blood vessels from being harmed. And there's other major advanced technology options that are available to us so that we can better put in your knee or hip joint. So conventionally, we've had alignment rods and all these gadgets that we put in inside you in surgery, and they have advantages and disadvantages. The advantages of conventional alignment is that it's the standard of replacement. We've been doing this for many, many years, 40 years of putting hips and knees in using these kinds of technology. And for the most part, patients have done very well. There's a 90% satisfaction rate with hip replacement surgery. And so it does pretty well. So we're really just trying to get that extra 10%. And so we really think that technology can get us there. But conventional does very well. It's cheap. These techniques have been around for a very long time, and they're user-friendly. Again, everybody's trained on these cutting jigs and alignment guides, and so they're very user-friendly. However, they have disadvantages. You have to eyeball, as you can see on the upper right-hand side, just to orient you. This is a hip. This is a hip socket, and so you have to be able to look at that cup and say, "Yeah, that looks good." And that takes repetition. It takes many, many surgeries for you to sit there and say, that's the good, proper position of that cup. But you can never be absolutely 100% sure by eyeballing. Down below is how we use the knee guides. So that guide right there is on the tibia or the shin bone. And as you can see, the doctor is using a ruler to measure. But as you can think about, that's a pretty thick calf muscle right there, right? So obviously that's going to change from patient to patient. Some people are going to be skinnier, some people are going to be larger. And so this makes it more difficult. And so you have to eyeball these things and it can throw your alignment off. And then after your bone cuts, after we make the bone cuts, you're kind of limited. You can't really do very much afterwards. So if you make a mistake, it's very hard for you to go back and correct that mistake that you make. And then also with conventional techniques, especially in the knee, you have to violate the femur. So here's an implant instruction. As you can see, you're putting this big rod down the femur, and that would not be an option for this patient that I recently operated on. He had broken his femur when he got hit by a car riding a bicycle. And so if we were using conventional techniques, we would have to remove that rod. So you'd have to have 2 surgeries in order for you to have your knee replaced, because we'd have to take that rod out before we ever do the surgery on your knee. And so with advanced technology, we can avoid that. So one of the advanced technologies that are very popular is what we call navigation. There's at least 20 different navigation systems that I can think off the top of my head that are available worldwide. but really it's probably 50, maybe even 100 different kinds of companies that create these navigation systems. And so there's many different ways that they can use this. And as you can see, it's very variable. They vary from handheld devices like the one in the middle to fully computer supported structure, as you can see down below. And they do have advantages. They are cheaper than robotic surgery, but it is more expensive, on average about $750 more per surgery using navigation. But the advantage is that it's available for any implant system. So your doctor can use any system or company with these navigation techniques. So that's a huge advantage because one system may not be the right system for you. It also doesn't require, some of these do not require imaging before you have surgery. So you don't have to have CAT scans or MRIs or even x-rays before to know how to use these properly. But there are disadvantages. There is a steep learning curve. It's very difficult. I've used several of these in the past, and they're very difficult to use, and they're not always accurate. They can be very inconsistent. And so if you aren't using these properly and you're not used to doing hip and knee replacements, you can be thrown off if you're reading the results wrong or using it wrong. And I've had some that just, quite frankly, they don't work. Some do not help with prior surgical steps, and that's probably the most of them, meaning that when we get into surgery, basically it's just to check our work more than anything else. And so we do the whole entire surgery, and in the very end, we basically hook this navigation device up, and it just checks our work. It just says, okay, does it look good or not? And then you make just small minor adjustments, but you can't make major adjustments if you made a major mistake. So there can be a disadvantage to using this. And like I said, not all navigation systems are equal. Some are better than others. Some are easier. Some are more consistent than others. So not all navigation systems are great for you. And they don't necessarily make the surgery safer for you. It can make the surgery last 20 minutes or longer because you have to put it together. And again, you're not saving yourself steps like you would with other modalities. So it does have some disadvantages having a navigated knee. There was a lot of interest in what we call patient-specific instrumentation, which is basically personalized instrumentation for you. So that was a big selling point because, again, everybody is different. Everybody has a different hip. Everybody has a different knee. Your anatomy is different. So this allows you to tailor it specifically to what you have as for your anatomy. But there's all kinds of companies that have tried this, and this is just a looks like about 10 different types of different companies that create this. And these are specific to the company and their implants. The advantages of them is that all the planning is done before surgery. This is a sample of what the surgeon would have to their disposal before surgery, and all the planning that is already done. So it makes the surgery, could make the surgery a lot faster because there's no thinking, you're just doing the surgery. You can customize it to your anatomy. And also to your deformity or your arthritis. And like I said, it can theoretically decrease the surgical time because there's no more thinking. It's just executing the plan. They can even 3D print your body part. So here is a 3D printed tibia with a cutting jig on top of it. And so the tibia is the part on the right and the jig is on the left. And so it helps the surgeon know how to put these implants in properly. And these can also be disposable as well. So it's less instruments on the table, less instruments that can get contaminated. And so there's a theoretical decrease in risk of infection. And so this is a company that I've used a lot when I was in fellowship called Conformis. And so this is all the equipment they have for you to put a hip and knee replacement in, or for a knee replacement in. It's very, very simple, very quick to put in. but it can be very finicky. This is one of the disadvantages. Another disadvantage is that you have to have advanced imaging currently. You have to have an MRI, or you have to have a CAT scan. And so that can be expensive for the patient or for the healthcare system in general, for every single patient. Because as you can recall, we do almost 1.5 million knee and hip replacements in a year. And so adding to the cost of doing an MRI and CAT scan can be costly. The cutting guides can break. This is very flimsy plastic. It's easy for you to break it. It's easy for the drill to break as we're putting these implants in or devices in. And it can be very finicky. It has a steep learning curve as far as how to put these in properly so that the jig is on there correctly, so that we can make the cuts more precisely. And so you can still make an error because nothing's guiding you other than that you're clicking it onto your femur or onto your tibia and then making the cut. So you can still easily make an error and it may not be precise. And personal cutting guides itself is expensive. Not only that you have to pay for the MRI or the CAT scan, but even making these custom, which takes 6 weeks for them to make, is very expensive. And so that's something also to consider. The last advanced technology are robotics. And there's only 3 quote unquote robots that are on the market today. These are the ROSA, NAVIO, and MAKO, in which I'll detail in a little bit further. The first one is ROSA. It's from Zimmer Biomet, which has the advantages of allowing their implants to be cementless. So that is a big advantage. And it does extremely well as far as their implants go. In fact, there's 3 different implants that you can use with the ROSA robot, which is not an option for some of the other ones. And it's x-ray based. You don't need to have a CAT scan, don't need to have an MRI prior to surgery. However, there are some major disadvantages with this. It's not really a robot. If you look at this picture where the guy's finger is pointing, that's just a normal cutting guide that we would use in any conventional surgery that we would do. And so basically, it still allows you to make errors. You still have to use that saw, get it through the slot just right, and you're getting no feedback at all. You don't know how far you're putting that saw in, so you have to go off of experience. You have to be very careful right here. And then also the disadvantage of the ROSA is that it can only be used for knees. It can't be used for hips or other body parts. The NAVIO, I do have experience in. I used this in residency during my last year. It has the advantages of not needing prior imaging either. So again, no CT or MRI prior to it. Their implant also can be used in nickel allergy. This is their implant, they call the Journey 2, which is made of oxinium. That's that black part. However, I put an asterisk right there because the bottom part is still made out of metal. And so because it's made out of metal, it still may have some nickel in it. So kind of a gimmick right there. But it's less expensive as far as the robot itself. It's about half the price of a ROSA and of a MAKO. One of the major advantages of the NAVIO is that you can dynamically balance the knee. And so if you take a look at the computer programming down to the bottom right, you can see this curve. And this curve basically shows that the balance changes as we go through a flexion and extension of your knee. And so that's a major advantage of putting in your components just right. However, the disadvantages of this is that it is a longer surgery. It took me on average 40 more minutes than it would for me to do it by conventional means. And so there's risks that go along with that, anesthesia and infection. Also with these particular devices, you can't do a cementless option. Everything has to be cemented in. There's no haptic feedback, but it does allow boundaries though. So you can't, it won't let you go over and get into anything that you're not supposed to. But it doesn't tell me if or how deep I'm doing anything. And it's only for knee joints. The MAKO is the robot that I use personally because I think it's one of the best. The advantages is that we do preoperative planning. So we get all of our planning before surgery, and so it makes the surgery a lot quicker because there's less intraoperative adjustments we have to make. Because of the robot arm, as you can see, the surgeon has the robot arm and the saw is actually attached to the robot arm. We can make smaller incisions because the robot is doing most of the surgery. We're just pulling a trigger and looking at a screen. Also, as we saw earlier, we get the haptic feedback. I know when I know basically how it feels as I'm cutting through the bone. It tells me when I'm getting too close to anything. And then it even has the boundaries so that I can't get into the structures that would be detrimental to the surgery. And it's also been on the market the longest. The NAVIO has only been out for 2 years. The ROSA is still not readily available to most surgeons. It's been out for only a year. The MAKO has been out for many years. It was bought by Stryker in 2013, but has been around since the early 2000s. And also that you can do hips and knees, which is different. The disadvantages is that it's kind of bulky. It's kind of bulky to use. It does require advanced imaging. It requires a CAT scan before surgery. So therefore it can be expensive. And even the capital cost of even buying the robot is very expensive for the hospitals. And so the other disadvantage is that you only have one design of implants that you can put in with the MAKO. So that's about it as far as the technology we can use to improve your outcomes for a hip and knee replacement. As far as where we've come from as far as recovery, and this will be just specifically immediately after surgery, and I'll leave it up to Chelsea to explain after surgery, after you're out of the hospital, what it can give you. So traditionally, patients in the 60s and 70s, they spent weeks in the hospital, even months in the hospital. Currently, today in Japan, you spend 21 days on average in the hospital after a hip or knee replacement. There's no weight bearing. So back in the day, we wouldn't even let you put weight on your brand new, spanking new hip and knee replacement. And we took extra precautions. We were very, very scared because of the complications that could occur. But then just recently, about 5 to 10 years ago, we were sending everybody to skilled nursing facilities. Even though we had cut down how long you'd stayed in the hospital, started to let you put weight on the joints, people were still spending 3 or 4 nights in the hospital and then going to a nursing facility for a couple of months even, which is detrimental because you're the healthiest patient there. You're the healthiest patient at the skilled nursing facility, and so you kind of get neglected sometimes. Also, especially in today's world where we have COVID-19, you can get infections. You're around a bunch of other people that may be sick. And so back then, the results for patients going to a skilled nursing facility were pretty poor compared to those that went home. But back 5 to 10 years ago, everybody went there because it was kind of like being in a hotel in a way. And so even when I was in residency, this was pretty common. Most patients stayed in the hospital for about 3 days. But now we've advanced, even in 5 years, we've advanced to the way we've recovered our patients. We have rapid recovery protocols that get you up from surgery that day. So the day of surgery, you're doing physical therapy. You're up walking with a walker. You're using the restroom. We typically keep you in the hospital for less than 23 hours. And then we even do outpatient total joint surgery as well. So at our surgery center, we send you home the day of surgery because you're healthy enough and able to do the things that you need to do. But that's also for very select patients. However, Medicare by 2025 wants 40% of total joints to be outpatient, meaning going home the next day. Whether that will happen, or going home that day, whether that's actually going to happen, may not. But and then also we have physical therapy that may come to your home as well. And then we also have advanced our ability to treat your pain using different methods with the anesthesiologist. And then as far as the physical therapists go, they have been absolutely super important for your recovery for the long term. And so these are my sources for today's talk. I'm going to turn it over to Chelsea, where she'll talk to you more about how outpatient physical therapy has changed.
All right. Hi again. I'm Chelsea Ostrander. I'm a physical therapist. As Dr. Bowman explained, there's a lot that has changed in the last couple of decades with total hips and total knees in the recovery process as well. So that's what I'm going to talk about a little bit. So some of the previous methods that we used in physical therapy to help patients recover were CPM machines, or continuous passive movement machines. If you've known somebody who had their knee replaced in the last 10 or 20 years, they probably told you about this device that bent and straightened their knee for them while they were relaxing on the couch. This is something that we don't use very typically anymore. They found that patients at 6 months did just as well with moving their own knee. Another device that patients used to get sent home with were knee immobilizers. This was something that was used a lot more frequently when femoral nerve blocks were used, because the big muscle on the front of your thigh, your quadricep, couldn't always work right after surgery. And so to make sure that you didn't fall down, they used knee immobilizers. However, this built up a little bit more scar tissue, made the knee a little bit more stiff, and they're not using femoral nerve blocks as much anymore. Longer hospital stays, as Dr. Bowman mentioned. The goal now is to get you in and out of the hospital as fast as possible, because the longer that you stay in the hospital, the more that you're going to be in bed, the bigger risk that you have of blood clots, the more that your muscles start wasting away, and the longer that you're in the hospital, the more opportunity for infections. So it's better to recover at home as soon as possible. So what do we do now? What's different? Biggest push is early mobilization. So this means that no matter if you had your total knee or your total hip in the hospital or in an outpatient setting, physical therapy is probably coming to walk you within the first 3 to 6 hours after surgery. At an extreme end, they might wait up to a full day, but we're trying to get you up and weight bearing on that leg as soon as possible. The sooner that you get up and moving, the less pain you're going to have in the long run, and the more functional you're going to be. A big push now is to get people into either home health or outpatient physical therapy as soon as possible. Our surgeons and research really supports getting to outpatient physical therapy as soon as possible. That first month is really critical. We lose a lot of that thigh muscle, that quadricep strength in the first month, up to 60%, as well as functional performance. And outpatient physical therapists have a lot more resources than a therapist coming to your home, so we can get you back to that pre-operative level and beyond a lot faster, so the results are a little bit better in that first month. However, sometimes there are other factors that happen that you need home health. Maybe you don't have access to a clinic, maybe there's other medical complexities. So the big push again is that you get into some sort of physical therapy as soon as possible. The earlier that you get moving, again, the shorter hospital stays, the better your function is down the road. Other more current concepts are the quiet knee. So again, if you know somebody who had their knee replaced in the past 10, 20 years, and you ask them about their physical therapy experience, they're probably going to tell you some pretty horrible nicknames for their physical therapist, that, you know, their sessions were ended in tears and we were pretty aggressive. We don't need to do that as much anymore. There's really this emphasis on what we call the quiet knee, which is less swelling, less pain, and it leads to better outcomes. We can do this because there's better criteria for somebody who's going to get a really stiff knee, so we have a better ability to predict who we need to be a little bit more aggressive with. Other modalities maybe that we use are things like electrical stimulation. NMES is neuromuscular electrical stimulation. That is a way to help facilitate your body to contract that big muscle on the front of your thigh. And the faster that we can engage that muscle, the faster that you're going to get back to walking and climbing stairs, which are two things that patients really want to get back to doing after they've had a knee replacement. Blood flow restriction training is something that is also new to us. There's a way to trick your body into thinking that you're doing a much harder exercise and gain muscle faster than in a traditional recovery. So this is something that might be an option for somebody after either a total hip or a total knee replacement. Prehabilitation is something that's on the horizon right now. There's not a lot of great research to support that. However, anecdotally, I think that getting our patients in at least just for one visit before you have a total hip or a total knee can be very beneficial. Giving you advice of what equipment you might need afterwards, teaching you how to use crutches or a walker or a cane before your surgery so that you can actually practice going up and down the stairs, walking around your house before that post-operative day when you're still coming out of anesthesia and you have this leg that you can't control as well as you normally can. Some surgeons will want you to do prehab before your total hip or your total knee because they want you to go into these surgeries as strong as possible, because the stronger that you go into these surgeries, the better your outcome is at 1 year post-operative. However, a lot of times once you're already scheduled for a total knee or a total hip, that joint is so far gone, it's so hard to get some of those muscles that are weak engaged that, you know, the best thing that you can do is once somebody has diagnosed you with arthritis, keep that joint as strong as possible, as long as possible. And one other new thing, especially with the pandemic, has been telehealth. We now have the ability as physical therapists to do virtual visits. Not as ideal as being hands-on and in person, but still have the ability to talk to a physical therapist, especially if you can't get to a clinic, go over questions, go over exercises, make sure that you're doing them correctly. So this is another great thing on the horizon, and it has been proven in research that we can be helpful there as well. It's better than no physical therapy at all. So yeah, if you have any questions, I'm happy to answer them.